Hello, my name is Mikis Euripides, and today we'll be providing you with the latest developments in the field of PARP inhibitors, or PARPis, as part of the World Ovarian Cancer Coalition's annual member meeting. And to that end, I'm delighted to introduce Dr. Ritu Salani. Dr. Ritu Salani is the Director of Gynecologic Oncology at UCLA. Her research focuses on clinical trials with novel therapies, best practices after cancer treatment, and improving patient-centered outcomes. Dr. Salani is actively involved in several professional societies, including the National Cancer Institute in America and the International Gynecologic Cancer Society. She has over 100 peer-reviewed publications and is a national and international leader in the field. Dr. Salani, welcome. Can we start with a very broad question relating to PARP inhibitors? I believe this is the 10th anniversary of the first PARP inhibitor being approved by the FDA. Could you summarize the key highlights in the research space that have evaluated PARP inhibitors over the last 12 months or so, perhaps picking out one or two that are of particular significance?
Yeah, so thank you for having me. As mentioned, I'm Ritu Salani, a gynecologist at UCLA, and it's really a pleasure to be here with you today. We've had a lot of exciting activity in the PARP space in ovarian cancer over the last decade, as you mentioned, and I think we've kind of really figured out where the role of PARP inhibitors are, but now it's become more challenges of how we can kind of capitalize or challenge patients with PARP inhibitors who've gained benefits. And so, there's been a couple of other studies, and this was more last year, where we saw some withdrawals of PARP inhibitor indications in the United States, and this is predominantly in the recurrent setting. And I think this highlights two things. Is one, we always want to prioritize patient safety and patient efficacy or outcomes. And so one of the things that came to light is that maybe in the second line setting, we're not getting as much benefit, although I do think the decision was a little bit, I don't want to say short-sighted, but I think it was a little limited in how they came to that conclusion. I'm personally disappointed that they don't have that as an option for patients who may not have seen it in the front line, but I think it's important that we do continue to explore what the exact right setting for PARP inhibitors in ovarian cancer is. And one of the things that's really come to light is the role in the frontline setting. And we've known this for several years and started initiating PARP inhibitor therapy over the last 4 or 5 years. And what this means is after the completion of primary chemotherapy, typically with a platinum and taxane-based regimen, we allow for patients to have maintenance therapy with PARP inhibitors, and there are approvals for all comers. We see the greatest benefit in the BRCA mutation population, and this has really been the most pronounced and most exciting area. And in 2023, we had a couple of highlights that I just want to share with you that kind of just reevaluate this role. And one of the, I think, really profound studies is SOLO-1, the 7-year survival update. And I just want to highlight that title in itself is an anomaly. We rarely get updates 7 years out. And so the fact that we're even talking about this shows you that this is really a home run. Now, SOLO-1 was a study of advanced primary ovarian cancer, chemotherapy, followed by olaparib, and this was limited to patients with the BRCA mutation. And the initial studies were really just impressive, and this became adopted as standard of care, a PARP inhibitor in the maintenance setting for BRCA patients, pretty much right off the bat. Later, other studies showed the benefit, although not as pronounced in the HRD patients and the BRCA wild type HRD proficient patients. But in SOLO-1, we see this true, just profound benefit. And I just want to kind of share with you some of the data. At 7 years, 67% of the patients who had received the olaparib were still alive. And this was compared to 46% of the patients who received placebo. So we're still looking at kind of better outcomes than we had seen, in years prior, but this really highlighted that the PARP inhibitor made a significant difference for these patients. Another statistic from the study was that the patients who were disease-free at 7 years, so these patients had never even had a recurrence, was 45% in the PARP inhibitor arm and 20% in the placebo arm. And 7 years is a long time from the initial diagnosis and treatment. And so, I think we're finally using the word potentially cured. When we think about ovarian cancer, we know that recurrences often are the rule, not the exception. And so here we're starting to see an area where we can truly make an impact. What was also really important is that these patients didn't have any additional safety signals with longer term follow-up. And what that means is we weren't seeing any new risk or toxicities from the therapy. And I think this is really important that not only did we improve the outcomes for these patients, we didn't create any additional harm by administering additional therapy. So I think this was really kind of one of the highlights for me of this year, and it just kind of reiterates the importance of this therapy and ensuring that every patient with a BRCA mutation is given this treatment if they're eligible.
Fantastic.
The others, oh, sorry.
No, and so just on the solo one before we move on, was that an international study or was that restricted to the US?
No, it was actually a predominantly ex-US study, but it was a global study. And so, it predominantly favored the European area, but it was a global study. And so this is applicable pretty generally. So all patients with BRCA mutation should be offered this therapy.
And is it the end of the line for that study, so to speak? Is there a next phase of that study, or are the kind of results in and as you mentioned, kind of the highlights there? Is that it for that study?
Well, I think we'll probably get another update as these patients continue to do really well. I hope to see a 10-year survival, but this is completely foreign territory for us that we've not seen this before. So, I'm not privy to that information, but I wouldn't say it's the end. I think as we get longer term data and information, the authors will probably still report out on this.
Great. So what's the one to look out for? Great.
Yeah, absolutely.
Fantastic. Thank you. Carry on.
So there is one other study I just want to highlight, and this is called DUO-O. And this was a study looking at also same PARP inhibitor, olaparib, in combination following chemotherapy. But the one kind of twist on this is they looked at the role of immunotherapy. Immunotherapy has been really exciting in the cancer world. But unfortunately, in ovarian cancer, we really haven't figured out where it really belongs, and many of our studies have not had a successful outcome. So this study looked at chemotherapy plus the immunotherapy, followed by immunotherapy and chemo and the PARP inhibitor. And the study's a little bit complicated. It was kind of designed in a way that's a little bit difficult to interpret. We clearly saw the benefit in patients who had the PARP inhibitor, and this was all comers, so it didn't matter if you had a BRCA mutation or not. So we clearly saw the benefit with the PARP inhibitors in those patients who had the BRCA mutation or HRD, which is kind of a tumor profile that we would see that kind of has higher sensitivity to PARP inhibitors. And then they also reported that they hit their primary endpoint in the all-comers group, so saying that every patient benefited from this. But it's a little complicated because they didn't have a, the way the arms were designed, you couldn't really see what the contributing portion of the PARP inhibitor versus the immunotherapy were. So the question is are we just adding more therapies without really understanding how much it adds to this? And so I commend the authors because it was a positive study, but I think it's difficult to interpret. I think we have to be cautious when we add more therapies because even though it was well tolerated for the most part, there are toxicities and there's also the financial expense of this. And if it's truly not adding a significant benefit to our patients, I think we have to just step back and kind of recognize that there may be other avenues that are more favorable or that this regimen may not be appropriate for all patients or even any patients. And so I think it's an important study. It asks an interesting question. I'm just not sure we got the answers we were hoping for.
Right. Okay, that's interesting. And is it right to say, I mean, on that particular side, is it right to say that there's a growing interest in combining PARP inhibitors with other therapeutic agents, such as immunotherapy agents? Is that a kind of a trend, you think, in this space?
I think the attractiveness of combining PARPs with another therapeutic agent or target is very exciting. And I'll talk about another study when we get kind of to the recurrent phase, but we have to be really thoughtful about why we're doing that combination. So make sure that we have kind of some synergistic effect, that we're not adding to the toxicity, because we know each drug's going to add a different toxicity profile, and sometimes those do overlap. Now, in this case, they didn't technically overlap for the most part, but we want to make sure that we're not causing severe bone marrow toxicities and things of that sort, or fatigue, where then it becomes intolerable and you're losing not only the kind of quality of life um, outcomes for the patients, but also preventing patients from getting an efficacious therapy because we've made it intolerable. So I do think that that's a really attractive approach, particularly in the recurrent setting, which we'll get to.
Great. Okay, fantastic. So, were there any other studies that you wanted to point out? I think you just mentioned, alluded to one.
So you talked, so there's one other study in the frontline setting that I just want to highlight really quickly. It's a
Yeah.
little bit of a smaller study, and it was done only at an institution at MD Anderson. And this was a study looking at patients with a BRCA mutation and seeing if they could give them neoadjuvant PARP inhibitor therapy. So a huge shift from what we typically do. So instead of getting chemotherapy, patients would take the PARP inhibitor therapy and then get the debulking surgery or the interval cytoreductive surgery. And they showed a really kind of remarkable response to these patients. Now, we expect these patients to be exquisitely sensitive to the PARP inhibitor, as they were only allowing for BRCA mutation patients, which makes the most sense, but really provocative data. After the surgery, patients had a hodgepodge of therapy. So some patients continued on PARP inhibitors, some patients transitioned to chemotherapy. So I think we need to figure out, but I think it's a really provocative study that really shows a proof of principle that PARP inhibitors, even in that setting of advanced upfront treatment, could play a role. And gosh, wouldn't it be exciting to kind of maybe eliminate or defer chemotherapy in these patients and still have really impressive outcomes? So stay tuned, a little early to kind of talk about, but I just want to highlight that trial of neoadjuvant PARP inhibitor therapy because I think it's really provocative.
Interesting. And you expect that when do you expect that to report in any way? Is that sometime over the next couple of years or next year perhaps?
Yeah, it's available in abstract form already, but I would imagine that they'll probably expand on the study before it's actually reported out. So just kind of it may be reported as kind of like early results, but I think to see true uptake of that approach, we would need to see a larger study. So hopefully that's the next step.
Great, fantastic. Okay, great. If we could just move on a little bit, sort of slightly broader theme. Many of the World Ovarian Cancer Coalition members are patients, patient advocates from all parts of the world, and often our advocates talk to us about how they can get more engaged when it comes to the research space and clinical trials in particular. Is there anything that you would say in terms of encouraging patients to get more actively involved, or what is it you think from perhaps the clinician side or the research community side that they could do to encourage greater participation in trials?
That is a great question, and we love our advocates and our societies that sponsor, awareness and patient education, because this would not be a functional, approach without advocacy. And I think clinical trials play such an important role. And I always tell patients, this is how we change the standard of care. This is how we get things better. And I'm so grateful to the patients who participated on Solo One and the other PARP trials because that's now standard of care. We want to do better, of course, but this is really important. And I think participating on clinical trials is really, really critical. And I think it's a challenge because not all places have clinical trial accessibility, and not all places have multiple clinical trials. And I hope that, one thing that I think would be really interesting is if the clinical trial, whether it's industry, institutions, or, cooperative groups who conduct the clinical trials, continue to work with patient advocates and give them information about the clinical trial so they can disseminate it on through their networks as well. Unless a patient comes to me and I have access to clinical trials, I may also not be able to tell that patient about a clinical trial at, another institution because I just don't know. And so I think understanding what the landscape is, what's out there, and then where those trials are. And I recognize there's challenges that, if there's not a trial kind of in your regional area, traveling to another place for a clinical trial may not be feasible. So there are those barriers that we have to continue to kind of address. But I think for the most part, and the trial sponsors are usually very savvy about making sure their trials are geographically distributed in a fashion where people have patients have readily access to those trials. But I think being aware of it, and your doctor, if they're not aware of it, it's important that the patient advocates for it and asks, are there any clinical trials I qualify for? but that answer should not be limited to that one site. So, if a patient asks me that, I say, well, we don't have anything here, but there may be something at these other sites. Let's explore. It's sometimes hard for the physician to do that and know the landscape of the trials around them. And this is where these advocacy groups can really play a role. And I think the important questions are, who qualifies for these studies? What is the data that supports this trial? And then studies are typically phase 3 studies are typically randomized. And what that means is a patient may get arm A or arm B, and we don't select it. It's kind of a random allocation. And if you get arm A, what does that mean? And if you get arm B, what does that mean? And how do you interpret that? Because I would never want a patient to go on a trial and then feel like they got, the short straw. We want the arms to be, as best we know, equal, or that the study arm, what's being explored, may be potentially better. Doesn't always end up that way, but that's the important thing, that you're getting the standard of care or what we think may be better, and now we're trying to prove that. And so I think when you're thinking about clinical trials, asking, and then also, the internet can sometimes be our best friend and worst enemy, but I think doing a quick search and looking at what trials you may be eligible for, and actually using those names of those trials or getting some more information. And for patients who may not be part of an advocacy group, hopefully having an advocate who can help you understand that information may also be an opportunity. I think one really interesting area of clinical trials that I would really love for patients to participate on is the study of PARP inhibitor therapy after prior PARP inhibitor therapy. And this is what I alluded to earlier.
Yeah.
And so this is something that we've all kind of thought about, especially in patients who have a really remarkable response to PARP inhibitor therapy and then have a gap in their care. But there are a couple trials of looking at, if a patient's responding to a PARP or having an okay response but then progresses, can we actually make that resensitize their tumor to that PARP inhibitor therapy by combinations? And there is an interesting study that is ongoing, and it's looking at PARP inhibitor therapy in combination with another target called ATR inhibition. And so ceralasertib is the drug that's being used in combination. And so it's re-challenging patients who have progressed on prior PARP inhibitor therapy using PARP and another agent to see if we can capitalize on that. And this is just one of several studies or concepts that have been designed. There are studies looking at other combinations as well. We talked about immunotherapy. There are studies looking at VEGF, such as bevacizumab, also known as Avastin. So this is a really interesting area of growth and development, and really exciting, because we found a therapy that really works well in the front line, and if we can re-challenge patients with it and get ideally, equal outcomes, I think that would be a win. And so that's something if you've received a prior PARP inhibitor therapy, that's something that I think should be on your radar. And I think it's the kind of next wave of PARP inhibitor studies.
Fantastic. That's really good. Thank you for that point at the end. Dr. Salani, thank you so much. Thank you for your time, and we hope to do this again sometime. But thank you for now.
My pleasure. Thank you so much.